Good morning.
Morning.
Good morning.
Can you hear me okay?
Good morning. Can y'all hear me?
Hear me okay?
I have sound. Should be loud. Good morning. Good morning, Sandra. Can you hear me?
Oh,
I can.
Okay. Good morning. How are y'all doing today?
Good. Just finishing up some breakfast. That's about it. And at work, of course.
Oh, okay. Making that money. What do you have for breakfast?
Some pancakes and sausage and a hash brown.
Oh, okay. Is that yours or you got it from somewhere?
Made a quick stop to McDonald's.
Right. It works. It works. Hey, Sandy. Good morning. She can't always. She can't hear me. Can you hear me, Sandy? Hello. Oh, you're on mute. You might be on mute. She's on mute. Yeah. I can't unmute you. I think I muted her yesterday because she had something going on. I can't. I can't hear you. I can't hear you. I don't know if she knows how to unmute it. I can hear you. And I can't unmute you.
For
Yes.
chapters 33 and 35,
Uh-huh.
I didn't have the PowerPoint until like later that night when you sent them.
Mm-hmm.
Everything that I have on there, I kind of knew from like knowledge before. So
Okay.
excuse some of it if it's like wrong.
You didn't look in the book?
No, because I didn't even realize any, like, I forgot all about the Kindle. Like, I forgot I even had it. And I was like, oh, crap. So,
Okay. All right. We'll see how it goes. Hey, good morning, Sean Berry.
Good morning. How are you?
Good. How are you?
I'm good.
Good morning, girlie.
Morning.
Good morning. Uh-oh. Is that you? Did you sound funny? Are you okay, girlie?
Me?
Yes. Oh, I thought
Yes, I'm good. I'm good. Thank you.
good. I thought you sounded hoarse for a minute.
No, I'm good.
I gotta watch out for that. Y'all be passing virus through the phone or something. Wow. Well, I'm gonna give them a couple of minutes to come on, and we'll start. Oh yes, our regional. I don't know. She's a regional director, manager, something. Um, Mr. William Ford is our director of education here, and then his boss. Her name is Melissa Ryan, who actually used to be my boss when I worked at the other school that I worked at in Jacksonville, or our campus president, she was. Anyway, she's a regional director here over education, I guess. Anyway, she is possibly going to be popping in on our Zoom today. So if you see somebody else, then that's what it is. They have to kind of monitor to make sure I'm not telling you stuff that's wrong.
Okay.
Good morning, good morning, Rebecca.
good morning, everyone.
Good
Morning.
morning. Good morning, Sharon. How are you doing?
Good morning. I'm doing okay.
Okay, good, good. All righty. Let's see. Something else I wanted to give you guys to do. Okay, so everybody pretty much, it looked like you guys did really good about getting in touch with each other for the project, the group project. Did you all have a chance to get together or talk yet, or did you set up a meeting time?
We did a Zoom this morning.
Oh, excuse me. This morning. What?
It was 30 minutes.
Okay, good, good, good.
Yeah.
And so, did anybody have any questions about anything? Oh wow. I'm proud of y'all. That's good. That's good. Nobody questions? Okay, good. Good. So just keep on working on it, getting together, doing whatever it is that you need to do. Getting your information. Please make sure that whatever information that you get, that you are using reliable sources. I guess, of course, you can always use your book if there's anything in there that pertains to your area. But please try to not get these weird, random, whatever websites. Please make sure that maybe it's like educational sources are good, colleges are good sources, any type of medical journals or official journals or websites like that are good sources. Definitely not Wikipedia. That's not going to do. And don't just Google and have no idea where the information comes from. Google told me, no, I don't want that. We want some legitimate sources that you are referring to or getting your information from. And you can divide it up, assignments, you can divide them up. If you want to pick a lead, then you can pick a lead if that's what you want to do, however it is. Also, another thing that I want to add to that is I would like to, I am going to be sending out kind of a mini grading scale for each student so that you can kind of let me know or give me a grade for the other people on your team. That's going to help you all to stay accountable. I need you to basically, like I said, just let me know what you think about how they did. Were they a team player? Were they good to communicate with? Whatever it is. And then that's going to be a portion of your grade for the project too. So we don't want any divas or divos. We don't want anybody coming in, trying to take over and nobody being rude and mean and all that kind of stuff. You need to be mindful that the people that you are working with are going to be grading you. They are going to be grading you on your participation in the group. So just be mindful of that. If they're not, and if they didn't do anything, if you try to meet with them and they didn't show and they didn't do their part, I want to know that too. And don't worry about anybody else knowing what you sent me. What you sent me is going to be between me and you. Okay? So don't worry about, nope, if they find out that you said, no, we're not going to do any of that because that's my business. That's not anybody else's business. And I think that's fair. It helps to keep
No drama.
Right, exactly. And I want to make sure that we're keeping everybody accountable. I don't want it to be a team assignment and then all the work falls on one person. That's not fair. And then everybody, they do an amazing job and get an A, and then everybody, even though they didn't work, no, that's not going to do. So just let me know. Like I said, toward the end of the project, I'll be sending you out that evaluation so that you can evaluate your other team members. All right? All righty. Okay. Also, there have been some issues. Some of y'all in this Survey Monkey. I don't know what it is. I don't know what it is. I think everybody pretty much on here is doing pretty well in making sure that they get them done. But y'all, please, 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 um, get them done as soon as possible, as early as possible. Get those questions in because that is your attendance for the day. And I can mark you as participating in Zoom, and I will do that, but it still doesn't register as your official attendance until you complete that Survey Monkey. So please make sure that you are doing that. I'm not going to ask you to go out now or do it now because I don't want you to log off and then forget to come back on or whatever, get distracted. But as soon as we finish this, I need you to go ahead and send that to me. I don't know where I put it. Somebody, Zayla is asking for the link to the Zoom. Something in here, somewhere in here. Well, all right. Oh, she found it. Good. Okay. All right. So I do have a this chapter 8 PowerPoint that I wanted to go over. And then I have a couple of other documents that I wanted to show you. Come on. All right. So chapter 28 is nutritional support and IV therapy. Now you yourself are not going to be responsible for setting any of this stuff, any of these things up, but you will be responsible for a portion of the monitoring of it. Like I said before, I think I've said it in the lab and I'll say it again, you all are going to have more opportunity to actually see the patient and be with the patient than anyone else. More than the nurse, more than the doctor, more than anyone. And so it's important that you kind of at least have an idea about how the system works and what it is it's doing, okay? So there are some people, the doctor may order nutritional support or IV therapy to meet food and fluid needs for persons who cannot eat or drink because of illness, surgery, or injury, have problems eating or refuse to eat or drink, cannot eat enough to meet their nutritional needs. Anybody with any idea on what kind of patients, patients with what type of diagnosis might have issues taking in nutrition normally? Any idea of a patient, any kind of patient?
A half a stomach. They got food poisoning real bad and they ate acid.
Well,
No.
Cleft palate.
what is that?
Cleft palate.
Oh, cleft palate. Okay.
Yes.
Sure. Sure. A little baby with a cleft palate, they might not be able to, it might, if it's bad enough, they might not be able to actually get the bottle back far enough in their mouth. Y'all know what a cleft palate is? It's when a baby is born and the top of their mouth, the roof of their mouth, that soft part that gets burned when you eat food too hot, up in the roof of their mouth, it's actually open. And you know that the sinus, the nasal passages, I don't know if you know the nasal passages, and the oral cavity, which is the opening of the mouth, are actually just separated by a very thin layer of material. And so babies who are born with a cleft palate, that is actually open. It can be open all the way to the front. And I don't know if you've seen the pictures where they have the split lip. But that's those children a lot of times have difficulty taking in fluids and with the bottle. You have to like push it way back in the mouth, and there's just all kinds of different techniques that you have to do with them. And sometimes it's just not something that can be done. And so they do have to have nutritional supplements to support them if they're not able to have that. Anything else? Anybody else?
Digestive disorders?
Like what?
Oh, crap. Can't answer that one.
No?
I don't know. Not off the top of my head.
Okay. Well, sometimes patients who have, um, like patients that have pancreatitis, that are having issues with their digestion, they might have to have, like IV therapy to get nutrition. Let me see, sometimes cancer patients who are on chemo and radiation and they're not able to keep down any fluids or foods, they might have to have nutritional supplement. Um, and even like dementia, Alzheimer's patients who actually, in a sense, they forget to eat or something happens in their brain that keeps them from being able to enjoy the food, and so they can't enjoy the food, so they just stop eating altogether. They might have to have some nutritional supplements as well. And even now, your COVID patients that end up on the ventilator, they still need nutritional supplement, and so they can get IV or in some kind of therapy as well. So enteral nutrition is giving nutrients into the gastrointestinal or GI tract through a feeding tube. Gavage is the process of giving a tube feeding. Tube feedings replace or supplement normal nutrition. And this is what it looks like, this dark, milky, it smells kind of not too nice, milky looking stuff. Mostly it comes in a bag, but it might come in a bottle. And sometimes patients will have just a regular bag, and then you actually pour in like a boost or ensure for their nutritional amounts. And generally speaking, a boost or ensure is about 8 ounces. And so in order to maintain an adequate nutritional intake, they have to have at least 6 to 8 cans of that a day. Doesn't have to be all at once. Sometimes it's continuous. Sometimes they get what are called bolus doses, which means that they get it, they'll get a couple of cans in the morning or a certain amount of ounces in the morning, a certain amount of ounces in the afternoon.
Yeah, she too strong.
That Marquisha. Yes, girl. You don't put you on mute. Okay. And yeah, so they might have that. The enteral nutrition, common feeding tubes are nasogastric tubes or NG tube. Feeding tube is inserted through the nose into the stomach. A nasoenteral tube where the feeding tube is inserted through the nose into the small bowel. So that actually goes into the nose. It's, well, everybody talks about the test for the coronavirus, but it actually goes, the NG tube actually goes up into the nose, and it turns in the back of the nasal cavity and goes down into the throat. The nasoenteral tube goes actually past the stomach and down into the small bowel or small intestine.
You can usually feel that.
Oh, you can feel it. Yeah.
Yeah, you can feel it in your throat. It's so weird.
Oh, you had an NG tube before?
Yeah, I did. Like you can literally feel it when you swallow. It's so uncomfortable.
Yeah. 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 I don't know. And then there's the G tube or the PEG tube. That the doctor surgically creates an opening in the stomach, and then they insert a tube. These ones, the nasogastric tube and the nasoenteral tube, are usually short term, probably like a week to 2 weeks, maybe even a month or so. They might have an NG tube. But if it goes any longer than that, then they're going to consider putting in a gastrostomy tube or a G tube or PEG tube into the abdomen. If the patient is going to be on long-term supplemental nutrition. A jejunostomy tube, or J tube, is inserted into a surgically created opening in the jejunum of the small intestine. So that bypasses the stomach altogether and goes directly into the intestine. The percutaneous endoscopic gastrostomy or PEG tube. This one is a doctor inserts a feeding tube with an endoscope. PEG tubes are inserted similar to that G tube. So, intro nutrition formulas, the doctor orders the type of formula, the amount to give, and when to give tube feedings. Formula is given at room temperature. Schedule of feeding times, you might have a schedule. Like I said, they might be given intermittently. At least 4 feedings are given each day, and they can use a nurse or a feeding bag. Continuous feedings are given over 24 hours. So they use a pump with that, and it just continues to flow. They just get a small amount over an extended period of time. Sometimes patients don't, sometimes they'll do it slowly at first, or they'll give a little bit at first just to see how the patient tolerates it. Some people, they don't have any issue with it. They do just fine. Some people will have gastrointestinal issues as a result of that. So, like they might have nausea, they might have vomiting, they might have diarrhea, any one of those things. So those are just some things to be mindful of with your patients. Like say if for whatever reason they started tube feeding, and the patient, you could be monitoring to see if the patient is having issues with nausea. And I have these Ensure here because sometimes they do use this for that enteral feeding, Ensure or Boost, or for diabetics, they use a supplement called Glucerna because it's low in sugar for diabetic patients. And I'm sure they have some others, and they do have others as well. Intro nutrition report, you want to report the following observations at once. So if you're treating a patient or helping a patient and they report any of these, you want to tell the nurse right away. So if they have nausea, you want to let them know. Discomfort during the feeding. So like if they say they feel like it's coming back up in their throat or whatever it is, you want to let the nurse know about that. If they're vomiting or throwing it up, if their abdomen is distended or enlarged or swollen, you want to let the nurse know. If they're coughing or they seem like they're choking, the thing about the NG tube, it actually can curl up, and instead of staying in the stomach, it can come up and go into the windpipe, which actually are the trachea, which actually goes into the lungs. And the last thing that you want is tube feeding in a patient's lungs, because that's going to cause them to have aspiration pneumonia, and it could kill them. So if you have a patient that's if they're just coughing, can't seem to stop, then you want to definitely let your nurse know. Complaints of indigestion or heartburn, you're going to let them know about that. Redness, swelling, drainage, odor, or pain at the ostomy site. And this right here, that surgical opening in the abdomen, that is an ostomy site. It should not. Now, this is probably like a relatively new PEG tube because it's still stitched down. Some patients that have had it in for longer, the stitching will not be there. They might have gauze that's around this opening, and we'll talk about that later when we get in the lab, because you might be responsible for making sure that the gauze stays clean, at least initially. Now, when patients have had a G tube for a period of time, they don't necessarily have to have anything over it, but initially, because they will have some drainage when they first get it done. I'm going to kind of monitor that and make sure that it stays okay, that it doesn't, that there's no bleeding, that there's no swelling, that there's no pus or drainage coming from that. It doesn't have a foul smell or causing them pain. Fever, that's always a sign that you're going to look for to make sure that they are not febrile. Signs and symptoms of respiratory distress. We talked about that, the possibility of them getting some of that tube feeding in their lungs or they call it aspiration. Aspiration. Increased pulse rate can be a sign of distress. Sometimes patients can look like everything is okay, and then their heart rate is just up, I don't know, over 100 somewhere. So be mindful of that. Complaints of flatulence, like a lot of gas, that means that they might not be tolerating that tube feeding well, and then diarrhea. Aspiration is a major risk from tube feeding. Aspiration can occur during insertion, from tube movement out of place, or from regurgitation. To help prevent regurgitation, regurgitation is just throwing up. To help prevent regurgitation and aspiration, you're going to position the person in Fowler's or semi-Fowler's position. And I don't know, can you guys see this? I don't have my glasses on. Ah, shoot. All right, so this is that semi-Fowler's position where they're sitting up and their head is at this 45 or 45-degree angle. And then here, the Fowler's position where they're sitting up just a little bit higher. You want to make sure that if you have a patient, even if they're sleeping, that they are not, they're not laying flat. Because if they're laying flat, it's just like if they're laying flat when they're taking in those fluids, it can come back up into their throat. That's that regurgitation process. It can come back up into the throat, and they actually can choke on that tube feeding or aspirate. And so we don't want that to happen. So you want to make sure that wherever, even if the patient is sleeping, that their head is slightly elevated whenever they're on the tube feeding. Okay? All right, enteral nutrition. Persons with feeding tubes usually are not allowed to eat or drink. That is this NPO. Anybody remember what I told you that means?
Nothing by mouth.
Right, exactly. No per aura, nothing by mouth. So we want to make sure that they don't have anything. I know they got cheeseburgers in there. No coffee, no tea. If a patient is NPO, they are NPO. And this is generally this after midnight is generally when you have a patient that's preparing for a procedure. But even if they're not, but if they're on a tube feeding, they're not going to be having any kind of, most likely, they're not going to have any kind of normal drink or eating done. Now, if you do have a patient though that's got the PEG tube or the gastrostomy tube, the G tube, those patients might have, they might have intermittent feedings, and they might be able to eat regular food in between just to see how they tolerate it. Because sometimes those things are temporary, and if we can get the patient to eat normally, that's the optimal thing to do. Persons with they're not allowed to eat or drink. Like I said, feeding tubes can irritate and cause pressure on the nose, change the shape of the nostrils, and cause pressure ulcers. So if you have a patient that has a PEG tube, or I'm sorry, an NG tube, a nasogastric tube, generally it's going to get taped to the side of the nose somewhere. Anthony probably remembers that. And it's not necessarily the most comfortable thing. And so anytime you have pressure on the skin, what can happen to that skin?
It'll peel off. Like it'll start to get a little like, I don't know how to put it, but like it'll get irritated.
Yeah, it can get irritated. You can actually develop a pressure ulcer on any area of skin that has pressure for an extended period of time. So you have to be mindful of patients that have those NG tubes, and you want to monitor that skin around there to make sure that they're not developing. You know, the last thing that people want is a big hole in their nose because somebody didn't switch the sites of that, or you know, move that tape around, or at least loosen it up.
Usually they'll tuck it behind the ear.
Okay.
Usually, like when I had it, they
the
yeah.
Yeah, because they tape it here, but they have to tape it here to the nose, and then I guess so to the mouth, to the side of your face. It can be taped. And
Yeah, to the
behind your
side.
ear. Yeah, but even with your ear, you have to be careful because it's just like patients who are on oxygen. The nasal gas, the nasal cannula. I don't know if I have one. No, I have oxygen tubing, but no nasal cannula. Patients that have a nasal cannula, that's the tube that goes in either nostril to get oxygen, and it comes around and it goes over their ears. Um, Even those patients, the NG patient, whether they have a tube, a feeding tube, or if they have the oxygen tubing, you have to be careful because they can get sores right here in the tips of their ears. So be mindful of that. Um, Assisting the nurse with tube feedings. In some states and agencies, nursing assistants give tube feedings and remove NG tubes. I don't think that we do that here. You are never responsible for inserting feeding tubes or checking their placement. So you're not responsible for inserting them or checking to make sure that they're in the right place. We'll talk about how that's done, but it's not in your job description. But you will be responsible at least for monitoring the patient's condition while they have that. And also you might be assisting the nurse in putting in an NG tube. And we'll talk about that too. So much fun in the lab. Parental nutrition is giving nutrition through a catheter inserted into a vein. I should have never done this picture on here because that is totally inaccurate. Often called total parental nutrition or hyperalimentation. Nutrient solution is given directly into the bloodstream. Nutrients do not enter the GI tract. This method is used when a person cannot receive oral or enteral feedings. Oral or enteral feedings are not enough to meet the person's needs. So, and the reason I said this is not accurate at all is because if you have a patient who is on who is receiving IV nutrition, it's going to be kind of a thick solution, and the veins in the hand are generally very small and not able to support the volume of the fluid that's coming in. And so you never, and this is my fault, my bad, never going to see it in an IV like this for parenteral nutrition.
Would it be more towards the chest? Because those are where like the bigger veins are.
Yeah, absolutely. You're going to see those in like your subclavian catheters. You're going to have, or at the least, they're going to have what's called a PICC line, which goes right into that. Remember, we talked about with the blood pressure right in here, that antecubital space. So it's going to go into these larger veins here, and the vein actually is going to go all the way up and into the upper valves of the, it might go actually into the heart or at least close to the heart, so that whatever that nutrition is going directly into the bloodstream. Of course, once again, the same precautions, fever, chills, other signs and symptoms of infection, signs and symptoms of sugar imbalances, chest pain, difficulty breathing or shortness of breath, cough, nausea, vomiting, diarrhea. Increased thirst could be a sign that their blood sugars are being elevated. Rapid heart rate or an irregular heartbeat, weakness or fatigue, sweating, pallor, trembling, confusion, or behavior changes. Some of the things that you want to be mindful of that because the IV goes into some of the most delicate regions of the body. So you can imagine if you have an IV tube that's going in through the arm and it's going all the way up, almost into the heart or actually into the heart, the risk for infection, that's a very, very sterile procedure. It's not something that's done just by your average nurse on the unit. They actually, most often it's done as a special procedure. They might have nurses who are specifically trained to put those types of lines in. If it's a central line or a line that's going in the chest, subclavian, or like I said, central line, that's going to be put in by a doctor. Our responsibility, your responsibility, assisting a patient with TPN. The nurse is responsible for all aspects of TPN. You assist the nurse by carefully observing the person, and then you're going to assist them with their personal basic needs and activities of daily living. So if I'm giving IV nutritional supplements, what kind of help do you think that I will need?
Can you repeat that? Sorry.
If a patient is getting IV nutritional supplement, what kind of help do you think they will need? Anybody? Clarissa, what do you think?
Well, on the last slide, it mentioned how their like heart rate might be like irregular, so we'd want to do their vitals and stuff to make sure.
Okay, sure. Sure. But if you got a tube going in your arm, Rebecca, what do you think? If you have a tube going in your arm, what kind of help do you think that you're going to need?
I'm sorry. What was the last part you said? What am I going to use?
If you have a tube going in your arm, and if this tube is going in your arm, it's not, you can't just take it out. What kind of help do you think they might need?
Getting up? I'm not sure.
No?
Was it like using the restroom, eating?
Yes, using the restroom, well, eating if they're able to eat. And certainly
Well,
if
yeah,
they have to, if they have to get into the shower, they definitely will need assistance with that.
It'd just be their day-to-day life, basically, if they have that too, put in them.
Yeah.
Whatever they need help, basically, doing. Well, majority of everything.
Right. Activities of daily living, they're called. Just basic stuff. Doing their hair, they might need help with. If you have a patient that has dentures, they might need help with that. Mouth care. If, like I said, if they have to get in the shower, they would need help with that. Whatever it is. So that's going to be primarily some of the things that we're concerned about as far as patients with that. IV therapy or intravenous IV therapy. IV infusion is giving fluids through a needle or catheter inserted into a vein. Doctors order IV therapy to provide fluids when they cannot be taken by mouth. Replace minerals and vitamins lost because of illness or injury. Provide sugar for energy. Give drugs and blood. RNs are responsible for IV therapy. State laws vary about the role that and that of LVNs in IV therapy. So, yeah, any nurse is, according to state law, is able to insert an IV. And the nurse is going to be the one that's responsible for maintaining that IV, making sure that the bag that's hanging, that if it gets emptied, they're the ones that has to replace that. You cannot go and hang another IV bag. Cannot do that. But what you cannot speed up the dose or slow down the dose. You can't do that unless, yeah. I'm just gonna say that you can't. Maybe in an emergency, if it looks like the patient is, if you see that the IV tubing or that the tube is leaking and it's leaking all over the patient's bed, then that's not going into the patient. You can stop that IV. If it looks like the patient's arm is blowing up, like the IV, it's called infiltration. So it means that the little tube that's in the vein is actually somehow come out of the vein and is poking, and the fluid is actually going into the tissue that's surrounding the veins. If you see that's happening and the patient is complaining of pain, you can definitely stop that IV. But other than that, unless it's an emergency situation, you don't touch the IV. Only the nurse is the person that touches the IV. And I don't know if you can see it, but this one here is a zero 0.9 sodium chloride. You might not be able to see that very well, but that is called normal saline. Normal saline. And that's like so typical. That's probably the first IV that anybody is going to get. There are many prescription dose or many types of IV fluids that a person can get, but normal saline is like, one of the most common ones. Peripheral and central venous sites are used. Peripheral IV sites are away from the center of the body. Central IV sites are close to the heart. The subclavian vein and the internal jugular vein are central venous sites. So that would be up here in the upper portion of the chest. So below the collarbone into these major veins that are leading from the heart. So you can have some IVs that are actually going right here into these veins. Some people actually can even have them in the ICU. They can have some IVs that are going into their jugular veins, which are the veins that go, the large veins that go from the heart to the up the neck into the brain. Central line enters the body here, and then it actually goes into, it can go into the heart. And the fluid actually flows right there into the bloodstream. Whew, scary, right? Central venous sites are used for nutritional, parenteral nutrition, to give large amounts of fluid, for long-term IV therapy, to give drugs that irritate peripheral veins. So the central IV sites close to the heart, subclavian vein, the internal jugular vein, the cephalic and basilic veins in the arm are also used. Catheters inserted into these sites are called peripherally inserted central catheters or PICC lines. PICC lines, and we talked about those mostly for if they're going to have IV nutrition, most likely it's going to go through a PICC line. If you have patients who are on long-term IV antibiotics, it's going to go through a PICC line. Basic equipment used in IV therapy, the solution container is a plastic bag. That plastic bag. You have a catheter or needle. This is right here. Infusion tubing. And then you're going to tape it down. These things, of course, alcohol to clean it. And this is called a tourniquet. And that's going to become your very good friend here in a few weeks, guys. Aren't you excited? Woohoo!
Wait, what? What's gonna be our friend?
The tourniquet.
Oh Lord. Those
Flow rate is going to be, the doctor determines the flow rate. The nurse is the person who figures it out and actually regulates flow rate. Flow is drips per minute or milliliters per minute. If a patient is on a machine, it's going to sound an alarm to let the nurse know that something is wrong with it. As far as you are concerned, if the machine is alarming, it's your responsibility to let the nurse know that the machine is alarming. This is another regularly prescribed IV fluid is lactated ringers. Lactated ringers. A lot of times you're going to see those with your prenatal or postnatal patient. Anybody know what a prenatal or postnatal patient?
pregnant woman?
Yes. IV therapy, never change the position of the clamp or adjust any controls. Like I said, unless like if it's running all over the floor, then you're going to stop it. If it's going into if it's patient's arm is blowing up, then stop that IV. Don't just do that. You can check the flow rate if a pump is not used, and then if you have to stop, if something has really gone wrong and you have to stop the IV, you're going to let the nurse know immediately. If there's no fluid drip, you're going to let the nurse know. If it's going really fast or going really slow, you can let her know. And then when it's inserted, they do tape it. IV therapy is your state agency may follow regulations. They change dressings. Most often, peripheral site dressings are changed every 3 days, and the doctor gives an order when the IVs to be discontinued. You are not responsible for starting, maintaining IV therapy, regulating drug flow, changing IV bags, giving blood, or IV drugs. So that's it. That's IV therapy.
Will you be sending us this PowerPoint?
I can. Yes, sir.
Please and thank you.
Oh my goodness, y'all. Okay. Any questions about that? About IV therapy or intravenous fluids or feeding tube? Anybody ever had a feeding tube? Anybody else besides Anthony had a feeding tube or know anybody that had one?
I've
No?
seen it a lot on Grey's Anatomy.
Oh, Grey's Anatomy.
You already know.
Okay, yeah.
It does not look fun.
No, nope, it's not.
No,
It's
they're not.
actually a very uncomfortable procedure. And, you know, it's one of those it's a rip the bandage kind of procedure. You don't want to be slow putting an NG tube in. You just gotta, once you get that right path, you just gotta go for it. I put in so many NG tubes. Woo! But anyway, like I said, we'll talk about that when we get in the lab. You won't be responsible for inserting one, but you might be assisting someone else, trying to help that patient to be still. Generally, when they're putting in the NG tube, they're going to have the patient to sip on some water from a straw. That's going to help that tube to actually go down the throat and not go into the lung.
They did not have me do that. She told me to breathe in, and that was it. And she shoved that tube up there, and I was like, ah.
Well, that might be the new school way. I'm sorry, y'all, my light keep going out. Yeah, but old school way, they at least let you do something. You know, drink a little water or something, and help it go down. Plus, it's a distraction. You're thinking about drinking the water more so, or at least able to think about something else. Yeah, and so that is that. And then also probably when we come into the lab, we're going to do some stuff with dosage calculation so that we can learn how to convert from ounces to milliliters and milliliters back to ounces, so that you guys can do what you need to do as far as documenting your intake and output, which you will be responsible for that intake and output. So I really, 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 really need you guys to be ready to check off our hand washing tomorrow, check off for vital signs as soon as possible. As soon as
And what else?
possible. I'm sorry?
I'm sorry, what was that last one?
Checking off on vital signs as soon as possible. So as soon as you get your 15 at home, 15 in the class, or 30 at home if you're a virtual student, you will be checking off on vital signs. I do not need that paper handed back to me, but I do need to see that you got your 15 or your 30 pulse, blood pressure, respiration. Also, just right quick, respiration is what is one respiration? What's happening with one respiration? Sandra?
What's happening to respiration?
Yes, one respiration. What is that patient doing?
They're breathing. You're watching them breathe. Is that what you're looking for? Or are you looking for a number?
Yeah, no, that's what I'm looking
The
for.
breaths they're taking?
What are they doing when you're counting the respirations? How do you know when to count? You know,
You just look at their breathing.
yes,
We look at their chest or their stomach.
right. But how do you know what is one respiration?
One breath.
Right. One breath, what?
one complete breath. It's like when your stomach goes out and comes back, or whatever you're looking at. That's
Okay.
one breath.
It
I'm
is
not sure
when
what you're looking for.
it is when you inhale, when they inhale and exhale. That's one respiration.
You just wanted, okay. I wasn't formal, sorry.
One inhalation and one exhalation is one respiration. So inhalation, exhalation is one respiration. All right. So if we're checking pulse, where are we checking it at? Most often.
The wrist.
The radial pulse.
The
Yes,
radio.
radial pulse. Radial pulse. Y'all got to learn this medical terminology. Speaking of that,
What is the neck pulse called again?
the neck. Are you talking about the jugular or the?
Yeah, the jugular. Yes. Okay.
Yeah. You have to be careful though when you're checking a patient here, because if you press too hard, you can actually block the flow of blood to the brain. And so, I said, yeah, I touched it. Yes. So you got to be mindful of that. You don't want to block the flow. You don't want to cause anybody to pass out trying to check their pulse.
You gotta do the radio.
Yes. But there are pulses all over the body, and we will talk about checking those pulses also. Let me see. Normal temperature. Geraldine, what's normal temperature range?
96 to 98.9.
Yes, 96 to 98.9 is normal temperature range. Sharon, what is febrile? What is pre-febrile temperature? Pre-febrile.
You said for the temperature,
Yes, pre-febrile.
isn't it over 100?
99 to 100 is pre-febrile. Over 100 is considered actual fever. That's febrile versus pre-febrile. Okay. When I'm asking you guys these questions, I'm going to be looking for the medical term, not just whatever. Okay. Marceline, what is normal blood pressure range? 120 over 80? 120 over 80 is the top. What's the bottom?
Systolic.
Nope. What's 120? What's the bottom of normal blood pressure range?
Oh, I'm sorry. I heard you wrong.
Uh-huh. Anybody
90
else?
over 60.
90 over 60. So if I'm asking you for a range, I'm asking you for the bottom of what is normal to the top of what is normal. So don't just give me one number. Give me from the bottom of what is normal, the bottom of what is normal to the top of what is normal. That's normal blood pressure range or normal pulse range, normal temperature range. Y'all got to watch those words to make sure that you are understanding what is being asked. Marquacia, what is a blood pressure that's over 140 over 90? That's 140 over 90 or higher. What is that called? We didn't really talk about that too much, did we? I don't know that we did. Anybody else?
Oh, is it hypertension?
Hypertension. Very good. She had to get back to her. Very good. Yes. A blood pressure 140 over 90 or higher is hypertension. What about that 120 over 80 to 140 over 90? What is that called, Rebecca?
Is it just hypertension?
Nope.
No.
Between
Isn't
120 over 80 and
Starts with an S.
it's pre-hypertension?
pre-hypertension.
Still
Yes.
pre-hypertensive. Okay.
Yes.
I
Pre-hypertension.
should know.
Girl, you and me both, right?
Right.
Let's not talk about it. Yes, pre-hypertensive is 120 over 80 to 140 over 90. That range that's in between there. Once it gets above 140 over 90, even if only one number is above, like say you might have one number that's in the normal range, but you have one number that's above the normal range. Either one of those is going to mean that that patient is hypertensive. Let me see. What is, Geraldine, what is normal pulse rate? Range, I'm sorry. What's the normal pulse?
1222.
Pulse.
Oh.
Pulse. Normal pulse range. You know it.
Oh. 60 to 100 beats.
Yes, girl. Don't play with me. I know you would. Very good. So what are we talking about when we talk about 12 to 22? What is that normal range for? Anybody?
Respirations.
Respiration. Absolutely. So anyway, how long are we going to check for our pulse rate? How long are we checking for a pulse rate?
30 seconds, then times it by 2.
30 seconds, and we're going to multiply it by 2. Why are we doing that, Anthony, since you went
For you don't have to do the full 6. For you don't have to do the full minute all the way around.
Why are we not doing the full minute?
Because that's a waste of time.
We ain't got time. We have other patients.
No. It is not because it's a waste of time. I mean, in the real world, yes, it is a waste of time. Ain't nobody gonna spend no 60 minutes checking a patient's pulse unless it's something that's unless they're, really doing bad and they want to actual check on that pulse rate. But it is 30 seconds. We're going to do 30 seconds and 30 seconds for respirations because what? What happens if you tell a patient that you're checking their respiration?
They're gonna
That's
try to
change.
They
fast.
start breathing weird.
Yeah, they're gonna either stop breathing, hold their breath, or they're gonna try to breathe and throw off your respiratory rate. So, in order for you to get a respiratory rate that's not altered by a patient's consciousness of you monitoring them, you're going to check their pulse rate for 30 seconds. You're going to multiply that by 2 or add that number to itself, however you want to think about it. And then you're going to check their respiration. Please don't stop after the 30 seconds and write down your number and then act like you're going back to check their respiration. Don't do that. You're just going to have to work on remembering that number in your head.
That was me yesterday.
Right. Yeah. I wonder where I got that from.
I gotta practice, that's all.
Okay. And that's all it is. Yeah, that's all it is. It's just practice. The more you practice it, the better off you will be. The easier it'll become. So just be mindful of that. Also, this Friday, probably what I'll do is, no, I'm going to say Friday. I'm not going to rush myself. This Friday, I'm going to, you will be having another quiz exam.
You're gonna have a what?
an exam. Woohoo! And it's going to be on the chapters that you did, 33, 35, 28. And it will also include vital signs stuff.
How many questions?
I don't know. You all in my business, girl. You in my business. You'll know how many questions when you get it. Okay. And then I'm also today, I am going to be sending you an email, but I'm not doing all these notes now. I hope that y'all know that when we're on Zoom meeting that you need to be taking notes about some of this stuff. I will send you that PowerPoint, and I'm also going to be sending you a list of abbreviations that we're going to start working on these. There are abbreviations that are used in the hospital or healthcare settings, normal abbreviations. We talked about a couple of them today, or a couple of them were mentioned today, but, and we've had some over the past few days. So I'm going to send you the list. I want you to start filling them in from what you think you know, what you find in the book, whatever it is, and we'll talk about them as we go. I'm going to be asking you questions about what does this mean, okay? And oh yes, Geraldine and Sharon were blessed with a list of definitions for some of these abbreviations. So you might want to try to hook up with them to see what you got on the list, girl, what you got on the list, okay? I'll see if I can find that list. I don't know what I did with it, but I'll see if I find it. If not, you can hit up your classmates and see what's on that list so that you can get the names of the list of the abbreviations. And then, like I said, we will be talking about them. I won't test you on abbreviations just yet, but it is coming up. Also, on this exam, it will include some of those videos listening to the Karateka sounds on YouTube, from YouTube. So you need to be able to tell me what is that blood pressure reading from that video. Yay. Yay. Y'all can do it. You can do it. I know you can because I taught you. Okay. Any other questions, comments, or concerns? Everybody on here is good. I got to reach out to some people today and see where they at. If you have any other questions, just let me know as soon as possible. Please, please, please make sure that when you when you do your, I think Marquesha, she did hers, I know. But from now on, what I want you to do is when you do your Survey Monkey, I want you to screenshot it and send it to me in an email so that I can see that you actually completed it. So that if for some reason they're not getting it in the system, I will have proof that you actually completed it. All right. So when you do it, I know that's adding extra work and all that. So I apologize about that, but I need you to do that for me, if you will. Just take a quick screenshot of it or take a picture of it, whatever it is, when you answer those questions. And then just, you can either send it to me, email, or text it to me. I'll give you that. Okay?
Okay.
All righty. All right. That is it for me for real this time. I hope to see everybody in lab tomorrow. I hope to see you all in lab tomorrow. And like I said, be ready for that exam coming up on Friday. It's going to be at least 50 questions. Geraldine. At least 50 questions. And I think that I'm going to keep that format. I like that when you guys just put the answer in the email. That's so nice. Woo.
Girl, do you know how long that takes? I was there for at least like 2 hours typing my little thumbs away.
All right. Well, we'll see if we can modify it some kind of way. I don't know. I don't know. We'll see. I might cut y'all some slack, but we'll see. All right. That's it for me. Y'all have a great day. We'll see you later.
Bye. See you tomorrow.
Okay.
Bye. See you guys tomorrow.
Bye-bye.
Can you explain to me what a PowerPoint is? I'm really not understanding that one.
That I just showed you is a PowerPoint.
The video?
Yeah, those pictures. Did you just
Yeah.
see that? Yeah, that is the PowerPoint.
Oh, okay. I was thinking it was something else. All right.
Uh-huh.
Did I miss anything in labs yesterday?
We were just doing hand washing and vital signs.
Sorry I couldn't be there.
That's
Dennis,
okay. How's your husband?
he fell. Paramedic party. We didn't take him to the hospital. They were going to put him on a stretcher. I told him no, because last time he was on a stretcher with his back. I told him no, he had a doctor. I made sure I had a doctor's appointment. But anyway, that's what happened yesterday. I'm sorry.
Oh, that's okay.
He's not, I've got to get that. I'm getting it ordered. I don't know how it's going to work because I need one that leaves the house. It's a box, one of those monitoring boxes. So if you fall, they monitor you, they contact you.
Oh, okay.
One of them boxes. But I need one that's like distance too.
Oh.
Because he's fallen at the stores and stuff and passed out.
Oh my.
So I need them. So we need that box. The insurance company will pay for the box, but I don't know if they'll pay for, quote, the distance or whatever.
Yeah, I know.
I need it where he can travel.
I've heard that they said that they have some at like Walmart.
Yeah.
That has some of those emergency alert devices that people can have and wear out in the community. So that might be a place that you want to check to see.
Well, I'm hoping our insurance company will cover the whole thing.
Right.
And Friday, Hope, I'll be starting more hours. It won't mess me up because they told me I could stick. I told them I'm in class from 11 to 12 on the computer, and they told me that shouldn't bother anything. I said, good.
Okay.
I don't know where I'm going, but it'll give me 34 hours, which will help me get caught up on everything.
Oh, okay. So your husband's going to be at home by himself?
It's what?
He's going to be at home by himself?
Yeah.
Oh,